Hello, my name is Mike Ehrenstein, and I work at University College London Hospital in London in rheumatology. I'm participating in this video on hydroxychloroquine. I've received an honorarium from BlackRock to do so. Today we're going to discuss hydroxychloroquine, the use of this medication in clinical practice, and the benefits particularly in systemic lupus erythematosus, but also it's widely used in rheumatoid arthritis and other inflammatory and autoimmune rheumatic diseases. The particular focus today will be understanding the retinopathy that can rarely occur with hydroxychloroquine and how to screen for that, the dosage used and the recommended dosage. So we're going to address the following points. What are the current hydroxychloroquine weight-based dosing recommendations? Should it be actual body weight or ideal body weight? How we keep hydroxychloroquine dosing simple in the clinic? What are the latest Royal College of Ophthalmology guidelines about hydroxychloroquine retinopathy? And practical considerations about how we interact with the ophthalmology service when we're prescribing hydroxychloroquine. The Royal College of Ophthalmology have recently updated their guidance, and they've taken very much a pragmatic approach about body weight, which for myself, being a pragmatic person, is most welcome, and have focused on actual body weight, 5 milligrams per kilogram per day, because that above that level predicts the risk of future retinopathy. Obviously using actual body weight avoids the need for some complex calculation in the clinic. It is important to try and aim for 5 milligrams per kilogram from the perspective of therapy, particularly in patients with SLE, because we know hydroxychloroquine is such an important treatment, and that we try and prescribe this medication for the majority of patients at that dose to achieve the maximum effect. The important things to consider about the hydroxychloroquine tablets are that, as we all know, originally just 200 milligrams each, and to try and achieve the 5 milligram per kilogram per day dose can be complicated with just 200 milligram tablets. For patients who are under 60 kilograms, then 200 milligrams a day is appropriate. For patients weighing between 60 to 80 kilograms, then 300 milligrams a day is the appropriate dose, and those above 80 kilograms, 400 milligrams a day. The 300 milligram tablet avoids the need of complex regimes, alternate day regimes, or asking patients to take 400 milligrams during the weekdays, but just 200 milligrams at the weekend. So I think patients will very much welcome the same dose each day. If it turns out they should be taking 300 milligrams a day, they welcome the fact they won't have to cut a tablet in two, which can lead to bitter taste in the mouth, or that they won't remember which day they should be taking the 400 or 200 milligram tablet. And adherence to the treatment regime can also be an issue. Patients not taking the required dose or the dose regime that the doctor thinks that they've prescribed, and having a simpler same dose per day for the patient will hopefully improve adherence. And that's so important, particularly in patients with lupus, where we know that achieving the target dose does prevent flares and improve both morbidity and indeed mortality. The Royal College of Ophthalmologists recently updated their guidelines in December 2020, and the main change was the dropping of the requirement for baseline screen for patients starting hydroxychloroquine, and to only start screening after 5 years of therapy. This will benefit the service because a lot of the demand on the service was for that baseline screen. And many patients do not continue the hydroxychloroquine beyond 5 years. Those patients who are at high risk of retinal toxicity, patients taking tamoxifen, those with impaired renal function, or those taking a higher than the recommended dose of 5 milligrams per kilogram per day, should start screening after 1 year of therapy. So, for example, we at University College London Hospital have identified an ophthalmologist interested in screening patients for hydroxychloroquine. I think having that good relationship and the clear referral pathway that allows does help to get patients to see the ophthalmologist. Clearly, dropping the baseline screening is a huge relief for many services because they were struggling to see the many patients who'd require screening. So I think with these new guidelines, approaching the local ophthalmologist and saying that the requirement has dropped significantly and that the burden for them would be much reduced, only occurring after 5 years. Another aspect for monitoring that is worth considering is the blood level monitoring for patients to ensure that they are achieving the required dose with the regimen that you've prescribed, and also to address any issues of non-adherence. Patients are clearly worried with all the news about hydroxychloroquine and potential retinal toxicity, and reassuring them that the risks are very low before 5 years if they don't have any risk factors will help. But blood levels could also be an adjunct to ensuring they achieve the correct therapeutic dose. So to summarize, hydroxychloroquine is a cornerstone therapy for patients with lupus. Most patients, unless there's a contraindication, should be taking hydroxychloroquine at the correct therapeutic dose, 5 milligrams per kilogram per day, indefinitely, essentially, because we know that it reduces morbidity and mortality rates. And the screening requirements for hydroxychloroquine and now that we no longer need to do a baseline assessment, that we can assess only after 5 years, which has reduced the burden on the ophthalmologist. And the introduction of the 300 milligram tablet ensures that we can simply recommend the same day dose every day for the patient based on their weight, rather than having to do complex dosing regimes. And I hope that this will improve the adherence for patients treated with hydroxychloroquine.